Good day. For this week's lecture, we will be discussing aseptic technique. Following the observations of Ignaz Semmelweis and others over 100 years ago, the practice of aseptic technique is an infection prevention method that is recognized as an important factor in the prevention and transmission of healthcare-associated infections. Aseptic technique improves patient safety and prevents healthcare-associated infections that may negatively impact outcomes, including increasing patient morbidity and mortality, increasing healthcare costs for patients and their families, prolonging length of stay, increasing resistance of microorganisms to antimicrobials, and increasing physical and mental discomfort for the patient. Let us define some key concepts in this week's lecture or topic. First is asepsis. When we talk about asepsis, this is defined as a process for keeping away disease-producing microorganisms. It is implemented to protect the patient by minimizing contamination to reduce the risk of infection. We also have two types of your aseptic technique. First is your surgical asepsis. It is the use of sterile technique to prevent the transfer of any organisms from one person to another or from one body site to another. The goal of our sterile technique is to maintain the microbe count at an irreducible minimum. The other type of our aseptic technique is we have your medical asepsis or clean technique. It refers to practice intervention that reduce the numbers of microorganisms to prevent and reduce transmission risk from one person or place to another. Since our main topic for this week is all about aseptic technique, so it would be better if we're going to define what is aseptic technique all about. Now, when we talk about aseptic technique, these are practices designed to render and maintain objects and areas maximally free from microorganisms and aid in the prevention of surgical site, urinary tract, bloodstream, and pneumonia infections that may be device or procedure related, including those with intravascular devices, urinary catheters, and indwelling drains or devices. Aseptic technique also use barriers, or it involves using barriers such as your sterile gloves, sterile gowns, masks, and sterile drapes to prevent the transfer of microorganisms from one care provider and environment to the patient during the procedure being performed. Aseptic technique should always be performed if you are going to perform or when placing invasive devices. Now, there are also other components of our aseptic technique. This includes using appropriate attire, hand hygiene, skin antisepsis, and appropriate use of sterile and clean devices, supplies and equipment, and environmental cleaning and disinfection. The Center for Disease Control and Prevention, or CDC, recommends that sterile dressing be used for incisions that have been closed primarily for the first 24 to 48 hours post-operatively, while the American College of Surgeons has recommended that sterile gloves be used for dressing changes performed during the first 24 hours after surgery. The use of sterile gloves should always be considered as a method for preventing the transfer of organisms to the wound site. An individual practice of the provider may include a double gloving technique that involves removal of the gloves after the debridement before completion of dressing change. There are two categories of our aseptic technique. These are your clean technique or your medical asepsis and your sterile technique or your surgical asepsis. When we talk about clean technique, these are medical aseptic practices that use clean and disinfected or sterile equipment and supplies to reduce the numbers of microorganisms and minimize the risk of transmission from personnel or the environment to the patient. Our clean technique may also be termed as a non-sterile technique, so there is no sterile-to-sterile rules apply for this technique. Remember that in clean technique, clean gloves instead of sterile gloves may be worn after hand antisepsis in most instances where clean technique is indicated, although sterile gloves should be used for cell dressing applications. Clean gloves may be used as long as the techniques used prevent the transfer of new organisms or movement from one site to another on the patient. A clean gown should be worn to minimize contamination of clothing following standard precaution guidelines. The following procedures are applicable for clean technique. First is taking blood pressure, examining patients, administration of enteral feeds, removal of an indwelling urinary catheter, endotracheal suctioning, removal of a peripheral IV cannula, and other procedures that can be carried out in an open ward by a practitioner using non-sterile gloves. Following are recommendations for clean technique. First is use clean techniques for routine patient care procedures. Reduce the number of skin microorganisms by applying antiseptic or skin antisepsis. Use barrier techniques to reduce microbial transmission from patient to personnel. So as what I have mentioned, your barrier techniques includes your sterile gloves, sterile gowns, masks, and your sterile drapes. Next is provide environmental controls to reduce microbial transmissions. Let's say, for example, in OR, it's a positive pressured room. So the air exchange as well as the pressure of the room could limit the number of possible microorganisms through air or within the environment. Then use germicidal agent for environmental hygiene and to clean up after blood and body substance spills. Clean and disinfect equipment after each procedure and every after patient use. Reprocess equipment between patient use. Discard disposable items after each patient use, and change cover of surfaces between patients. So do not forget these recommendations, guys, that in which we are going to apply clean technique or your medical asepsis. Another important topic that we need to discuss when we are going to talk about aseptic technique is we have your aseptic non-touch technique or your ANTT. Your ANTT or your aseptic non-touch technique, this is a developed technique to prevent microorganisms from being introduced to sterile or susceptible body sites during any invasive procedures that bypass the body's natural defenses. In this technique, non-sterile gloves are perfectly acceptable. We have principles of our ANTT or your aseptic non-touch technique that we need to keep in mind all the time. First is your letter A. Always wash your hands effectively, okay? In any procedure that we're going to perform, hand washing still is the number one prevention of any infection. Hand washing is the most significant procedure in preventing cross-infection or contamination. Organisms present on the hands are either resident or transient bacteria. Other principle of our ANTT is we have your never contaminate key part. Any key part must only meet other key parts. Now, what are the examples of our key parts? Let's say, for example, your syringe tips. The syringe tip should only meet the needle. Okay, those are key parts. Other key parts is we have your cannula tips, your vacutainer needles, rubber banks on drug bottles, giving set spikes, injectable ports, tip of eye drop dispenser, exposed lumens of catheters, and IV line connections. Those are your key parts that you should never contaminate or keep it clean or sterile as much as possible. Next one is your T, touch non-key part with confidence. So just like your the plunger or the body of your syringe, those are non-key parts. So don't be afraid on touching all those non-key parts. So you should not be in doubt if you are going to touch those non-key parts. Then last one is we have your take appropriate infective precautions like environment or air contamination, hands and gloves. For environment or air contamination, approximately 10% of all endemic infections in hospital are airborne. It would therefore seem reasonable to assume that potential for harmful contamination via this route is small in comparison to direct contact. Nurses can reduce the potential for airborne infection by taking sensible precautions such as avoiding procedures that require ANTT immediately after bed making or similar activities when airborne bacteria will be at its highest. For the hands, guys, maintaining asepsis of key parts is achieved by preventing them coming into contact with a significant amount of potentially harmful organisms. This is difficult as the very tools we use to perform ANTT are covered in bacteria, which is our hands. It has been estimated there are as many as 3 million bacteria present per square centimeter of normal skin. Pathogenic bacteria such as your Pseudomonas and Klebsiella can be harbored on hands for months. So this is very important that hand washing is the most significant procedure in preventing cross-infection. Organisms present on the hands are either resident or transient bacteria. Transient organisms are those that are not usually part of the skin flora. They are acquired by contact with infected patients or infected equipment. They can be easily removed by effective hand washing. Our own normal resident skin flora consists of mainly Staphylococcus epidermis and Staphylococcus aureus bacteria. These are normally deeply ingrained into the epidermis and cannot be totally removed by hand washing. Although effective hand washing can reduce the number significantly, however, research continues to highlight that many healthcare workers fail to wash their hands effectively. Although bacteria can be reduced by effective hand washing, it can be reestablished quickly over the entire hand surface in the warm and damp environment created beneath gloves. Okay? This is an important fact. As a study by some researchers, it highlighted that failure to wash hands after glove removal was the most frequent breakdown in universal barrier precautions. The next appropriate infective precautions as part of our principle for ANTT is we have your gloves. Choosing between sterile, non-sterile, or no gloves at all has become a contentious issue in IV therapy. The rationale for glove choice for the ANTT is based on the fact that there is no substantial evidence to prove that any particular type of glove reduces the incidence of IV-related infections. According to some study, the fact that colonization of skin by transient bacteria is likely to result when skin is repeatedly moist or damaged. Shredded skin caused by such damage can transmit bacteria via the contact route. Nurses often have moist and damaged hands owing to frequent washing and drying. Gloves may therefore serve as a barrier to prevent descaling of bacteria on the key parts. It was recommended by the Center for Disease and Control in 1987 that the wearing of gloves for all procedures involving potential exposure to body fluids should be worn, or gloves should be worn on those procedures or activity, and it was termed as your universal precaution or your standard precaution. The next category of our aseptic technique is we have your surgical asepsis or your sterile technique. The goal of our sterile technique or your surgical asepsis is to completely eliminate microorganisms. It involves the sterilizing of instruments, skin, and other articles that will be used to perform surgery or other types of sterile procedures. It is the destruction of all microorganisms prior to a surgical procedure, and sterile technique is a practice that eliminates all microorganisms and spores from an object or area. Settings outside the operating room may not have the capacity to follow the same strict level of surgical asepsis applied in the operating room. However, the goal to avoid infection remains in all clinical settings. For example, a critically ill trauma patient or neonate may be too unstable for transport to the operating room. Procedures may be accomplished in a radiology suite with access to invasive imaging procedures or at the bedside. In these circumstances, using environmental controls to maximize the reduction of microorganisms during surgical procedures is essential. Such strategies may include the following. First is use of special treatment or operating rooms. Second, managing activity to reduce airborne transmission if procedure are performed at the bedside. Keeping doors closed during procedure. Using physical barriers such as screens and diverting traffic in open units. Excluding visitors and unnecessary personnel. Avoiding cleaning activities in the area during invasive procedure. And last is providing additional environmental controls such as ventilation to further reduce contamination. These are the key points for sterile-to-sterile use since we are talking about your surgical asepsis or your sterile technique. So their sterile-to-sterile is applied. First is all objects used in the sterile field must be sterile, of course. Sterile objects become unsterile when touched by unsterile objects. So as what I have mentioned, it should be sterile to sterile, okay? Sterile items that are out of vision or below the waist level of the nurse are considered unsterile. So you need to keep an eye always on your sterile field or your sterile equipment devices. Then sterile objects can become unsterile by prolonged exposure to airborne microorganisms. So it should be, let's say for example, if you're going to perform procedure, you need to open your sterile packs as close as the time that you're going to start the procedure. And moisture on sterile field draws microorganisms by capillary action and is considered unsterile. Edges of your sterile field are considered unsterile. Skin cannot be sterilized, of course. And conscientiousness, alertness, and honesty are essential in maintaining asepsis. So, because it's common that there are some staff that since maybe they are afraid that they might be punished or whatsoever, so they will try to lie. And they will just tell to somebody that this one is still sterile, even though it's not. So it depends also on your how honest you are, or how are you as a staff nurse on promoting safety not only to our patients but also to the environment as well. And other key points for sterile-to-sterile use is we have do not sneeze, cough, laugh, or talk over a sterile field. When opening sterile equipment and adding supplies to a sterile field, take care to avoid contamination. Set up sterile trays as close to the time of use as possible. As what I have mentioned, make sure that to lessen the microbial transmission or contamination through air or the environment, make sure that if you're going to prepare all your things, prepare it as close to the time of use as much as possible. Then whenever the sterility of an object is questionable, consider it non-sterile. So if you're in doubt, throw it out or dispose it. Any torn, previously open, or wet packing or packaging that has been dropped on the floor is considered non-sterile and may not be used in the sterile field. And last is non-sterile items should not cross over the sterile field. Let's say, for example, for non-sterile person should not reach over a sterile field. These are the following procedures which require sterile technique. For non-invasive procedures, we have your wound dressing, as what I have mentioned during the first few slides, urine collection from the catheter, CVC dressing, changing of parenteral nutrition. For invasive procedure, we have your lumbar tap, incision and drainage, blood CS, aseptic tap, biopsy, bone marrow aspiration, and your vaginal examination. These are the recommendations for sterile technique. First is use sterile techniques for all invasive procedures. Prepare and organize equipment and supplies. Put on mask or facial protection when required. Wash hands at least a minimum of 3-minute hand scrub with an approved antiseptic hand soap. Apply friction with scrub, brush, or gauze sponge to maximize the amount of soil removed. Use barriers to decrease transmission of microorganisms from person to patient. Put on appropriate sterile apparel as required by risk of procedure to be done. And maintain area of sterile field with the use of sterile supplies like gloves, drapes, or equipment. Another recommendations or more recommendations for sterile technique is provide environmental controls to maximize reduction of microorganisms during procedures. These are what? Use special treatment rooms when indicated, like your OR or your radiology. Control activity to reduce airborne transmission if procedure is done at the bedside. Exclude visitors and unnecessary personnel. Keep doors closed during procedure, or use other physical barriers such as screens to divert traffic. Provide higher rate of air exchanges by ventilation system. Avoid cleaning or maintenance activities in the area during the procedure, and maintain positive pressure in the room. All staff or all members of the surgical team should observe the following. First is wear sterile disposable or single-use surgical gown and sterile gloves. Inside the operating room, do not walk around outside the theater with it. Use drapes impermeable to liquids and microbial contamination. Change surgical attire when soiled by blood or other potentially infectious materials. Wear sterile latex gloves for latex or powder allergies. Wear hypoallergenic and latex-free gloves. Put on gloves after donning a sterile gown. If gloves are punctured during the operation, change promptly as safety permits. Do not wear shoe covers for the prevention of surgical site infection. Wear dedicated shoes, not sandals, to prevent blood or body fluid exposures. All personnel moving within or around a sterile field should do so in a manner that maintains the sterile field. The following slide that we are going to discuss are the other components of our aseptic technique. Appropriate attire is based on the risk of the procedure and the area of the hospital where the procedure is being performed. And it is important to know or to remember that scrubs are not considered personal protective equipment. Based on the amount of anticipated soilage, personnel performing procedure resulting in splashing or potential exposure to body fluids should wear impervious or fluid-resistant barriers as well as face and eye protection. Additionally, some aseptic procedures such as insertion of central lines require utilization of sterile gowns. Depending on the aseptic procedure being performed, barriers may include gloves, gowns, and hair covering. Freshly laundered scrubs are worn in semi-restricted and restricted area or zones in the surgical areas to prevent microbial contamination from shed skin, squams, and particulate. Example, your lint. Transference to the sterile field, including the surgical site and patient. Additional attire, like your sterile gown, may also be required to reduce risk of occupational exposure to bloodborne pathogens and other potential infectious materials, as well as to maintain the sterile field. Head and facial hair covering and clean shoes should also be worn in the semi-restricted and restricted areas of the operating room. Masks should be worn in restricted areas when open sterile supplies and equipment are present. And you need to remove covering and surgical scrub attire before leaving outside unrestricted zone. Surgeons and theater staff should not wear with surgical scrub attire outside the theater. Other components of our aseptic technique is we have your hand hygiene. Hand decontamination prior to any procedure is an integral step of the process that should be done by the team working in direct contact with the patient, equipment, instruments, and/or sterile field. Maximum reduction of skin microorganisms without damaging tissue is accomplished when healthcare providers decontaminate their hands using an antiseptic hand rub or antiseptic soap before operative procedures. In surgical areas, scrubbing should be performed before donning sterile gloves. Long, natural fingernails, artificial fingernails, or any fingernail enhancement should not be worn by direct care providers of high-risk patients, like patients in the intensive care unit, operating room, oncology, or neonatal areas. The third component of other components of our aseptic technique is we have your skin antisepsis. It is imperative to use the appropriate recommended antiseptic for each procedure type as well as screening for contraindications such as allergies and age limitations. Antiseptic agents should be used following manufacturer's directions for use, including ensuring the skin is clean before placement as well as antiseptic contact and drying time. So we need to take into consideration the contact time, the drying time, and any recommendation from the manufacturer so that we may be able to achieve the quality of the antiseptic solution or skin antisepsis that we are going to use in every procedure. Other aseptic practices involves the use of single-use devices and equipment or reusable devices and equipment that have been properly processed and packaged. Personnel should maintain the sterile packaging and or container integrity to ensure an intact seal and confirm that sterilization indicators with expiration date, if provided, are verified. Before use, sterile packages should always be inspected for signs of contamination such as moisture, tears, or discoloration in addition to the expiration date. Items including solutions should be aseptically transferred to the sterile fields. If we are going to use these devices, instruments, or anything in a sterile procedure, like your disinfectant pads or swabs, alcohol, chlorhexidine, or betadine, including those in sterile kits or trays, they should be checked to verify that the label on their package indicates they are sterile. Otherwise, they are considered a non-sterile item. The last component of your other components of our aseptic technique is we have your environmental cleaning. Routine cleaning and disinfecting environmental surfaces with an Environmental Protection Agency or EPA approved hospital disinfectant, detergent, and the use of an efficacious germicidal agent for cleanup of blood or body fluid spills are both examples of controlling the environment to reduce the risk of contamination and microbial transmission in all patient care settings. In this area, we need to use clean equipment and supplies like mops, water, cleaning cloths for environmental hygiene. Most germicides recommend removing the original bioburden from the environment with cleaning agents and techniques, followed by the use of the germicide to disinfect the area. How do we maintain asepsis? If we are going to maintain our area or field aseptically, we need to be fully prepared before starting any procedure. Okay, so you need to know what are the things that you need to prepare so that you will not be coming back and forth into the sterile area or any areas. Anticipate what is needed for the procedure, of course. As a nurse, you need to know what are the things or what are the supplies that you need to know on a certain procedure just to save time and energy. Avoid leaving the room or bedside to get supplies. That's why you need to be fully prepared and you need to anticipate everything on a certain procedure so that you are not going to leave anymore just to get supply to your storeroom. Then change gloves after removing all dressing and before applying clean dressing. You need to change gloves. That is to prevent contamination from prevent contamination to a clean area coming from the dirty area. Preparation and dilution of medication are done by ready-made single-use, single-dose sterile solutions. Moreover, supplies are brought to patient's care area only when needed and after patient discharge. So this is very important. We have a finding during our visit that the supplies are already prepared in a certain area because maybe they are anticipating for procedure which should not be allowed. You need to prepare all your packs, all your supplies, the closest time during a certain procedure. Okay, then properly fix a venous cannula with date of insertion clearly written, and if needed, routinely change every 3 to 4 days for adults and replace only when clinically indicated for children. Continuously connect sterile urine bag to urinary catheter and evacuate with proper technique and appropriate PPE. Now for PPEs, if you're going to evacuate urine from a urinary catheter or bag, depending on the type of exposure, so you will be you will be anticipating exposures of body fluids, urine. So you need to keep in mind what are the PPEs that you're going to wear in order for you to be protected. And the last topic or the last slide for today's lecture or for this week's lecture is we have performance of nursing procedure in giving medications. First is multi-dose vials are used for a single patient if possible, dated when they have been opened and accessed for the first time and discarded after 28 days unless otherwise per manufacturer's instruction. So the reason why we need to label those multi-dose vials so that we will know when are we going to dispose or discard those multi-dose vials. And if multi-dose vials are used for more than one patient, whenever possible, it shall be kept and accessed only in the medication preparation area. So do not leave multi-dose vials, especially if you will be using that one for multiple patients. So do not leave it in a patient care area. It should be kept in your medication preparation area. Disinfect with alcohol the rubber seal. This is your vial. You need to disinfect the rubber seal once you remove the metal part. Cup of the medication, vial or IV solution, bottle prior to access. IV solution bottles are only accessed through the self-sealed rubber cup. Do not access anywhere aside from your rubber self-sealed cup if you're going to spike or to access the IV bottles. Replace IV sets, including secondary sets and add-on devices that are continually used to infuse crystalloid solutions. What are your crystalloid solutions? These are your the usual IV fluids, the 5-NSS, plain SSS, or normal saline. Not more than frequently than 3 to 4 days are interval for adults, and for children only when clinically indicated. And replace IV sets that are used to administer blood products, or lipid emulsion, or dextrose or amino acid TPN solutions within 24 hours of initiating infusion. Now, I know that usually if we're going to give, especially for blood transfusion, I don't know what is the practice in the hospital if we are changing the IV sets every after blood transfusion. But based on the standard, or ideally, it should be changed after 24 hours. And use sterile solution in nebulizer, humidifiers, or any aerosol generator, and change between patients or every 24 hours for the same patient, unless the manufacturer already made solutions or sterile solutions specifies different dates. Now, this means that, let's say, for example, if the patient is on autotherapy or nebulization, once the patient is discharged, you need to change the sterile solutions that you're going to use. If the patient is admitted, then you need to change the sterile water in the humidifier every 24 hours for the same patient. So that ends our lecture for the topic all about aseptic technique. I hope that you have learned something and you're going to practice all those things, and you need to keep those in mind, because those are the commonly asked questions if we are having audit, and it is part of the standard. Just recently, one of the comment that we received on the aseptic technique standards, that the staff should need more awareness regarding aseptic technique. So hopefully we are going to hopefully from this topic you have learned something, and we will not be able to have another findings with regards to these standards or issues or matters. So thank you very much, and I hope to see you again next week for another topic. God bless. If you have any questions, you can write it down in the form, or you can privately message me. Thank you.